Let us talk about gallbladder. And in gallbladder, we should know first the surgical anatomy. In the surgical anatomy, you know that there's gallbladder, and gallbladder is supplied by a cystic artery. And this cystic artery is a branch of right hepatic artery. Cystic artery is a branch of right hepatic artery. And this right hepatic artery usually behind the common hepatic duct. Behind the common hepatic duct gives this cystic artery. You are seeing it here that behind the common hepatic duct, the right hepatic artery is giving a branch called cystic artery, right? Now, if you look at this image carefully, you will find that there are two triangles there. One is a yellow triangle, another is the red triangle. And out of these two triangles, one of them is a Kellogg's triangle. One of them is a Kellogg's triangle. And which of them is a Kellogg's triangle? So this yellow triangle is a Kellogg's triangle, right? And the boundaries of Kellogg's triangle are common hepatic duct, cystic artery, and a cystic duct. This is a very commonly asked question, and there's a lot of confusion on this also. And then you can see a red triangle, and that red triangle is called cholecystohepatic triangle, or triangle of cholecystectomy, or hepatocystic triangle. The boundaries of this cholecystohepatic triangle are common hepatic duct, inferior surface of the liver, and cystic duct. Right? Cholecystohepatic triangle. Now, normally, in a normal scenario, right hepatic artery gives cystic artery behind common hepatic duct as shown. But sometimes what happens is, this can be a question again in exam. Sometimes what happens is that instead of giving a branch cystic artery behind the common hepatic duct, this right hepatic artery loops like this, and gives a short cystic artery. So when a right hepatic artery loops close to the gallbladder, and gives short cystic artery. Once a right hepatic artery loops close to the gallbladder and gives a short cystic artery, this anomaly is called caterpillar hump or Moynihan's caterpillar or Moynihan's right? Now, you know that all the veins in the body runs parallel to the arteries. All the veins in the body runs parallel to the arteries. So there will be corresponding vein along the cystic artery. And we also know by now that all the lymph nodes in the body are sitting on a vessel. These are those vessels which are supplying that organ. So that means there will be lymph node sitting on the cystic artery also. And this lymph node is the first draining lymph node of the gallbladder. This lymph node sitting on the cystic artery is the first draining lymph node of the gallbladder, and it is also called cystic lymph node of Lund. It is also called cystic lymph node of Lund. This is the first draining lymph node of the gallbladder. A question asked. Now, you all know this, that right and left hepatic artery joins to form common hepatic duct. Common hepatic duct. And this part where the right and left hepatic duct is joining, important point, is called hilum or confluence. Hilum or confluence. And then you all know that a cystic duct joins is a common bile duct. You know that, right? And the normal diameter, very important point, and question will be there on this too. The normal diameter of the CBD is 4 to 6 mm. Hilum. The normal diameter of the CBD is 4 to 6 mm. So anything more than 6 mm is considered as a dilated CBD. Anything more than 6 mm important, so they can give you the diameter of the CBD and they may expect you that whether the CBD is dilated or not, and if the CBD is dilated, our approach in a given scenario changes. So we should know when will we call a CBD a dilated CBD. So any diameter more than 6 mm of CBD will be considered as a dilated CBD. Now, coming on to the investigation. Now, can you tell me what are the investigations do we have per se for evaluation of the biliary system? Ultrasound, very good. One investigation is ultrasound. Any other you know? MRCP, okay, good. HIDA scan, good. Any other? Endoscopic ultrasound, good. ERCP, very good. Endoscopic retrograde cholangiopancreaticography. Endoscopic retrograde cholangiopancreaticography, right? Then we have CT scan also. We have PTC also. What is PTC? Percutaneous transhepatic cholangiography. Percutaneous transhepatic cholangiography. Now, these are the investigations you all are aware that they're there. But then you should understand, and they can ask you this question also. There is something called a direct cholangiography. There is something called indirect cholangiography. Direct cholangiography and indirect cholangiography. Now, what do you understand by direct and indirect cholangiography? We have to first understand, then only we can make out which is direct, which is indirect. Now, whenever you inject a contrast in the biliary system directly, whenever you inject a contrast in the biliary system directly, as the name suggests, it will be a direct cholangiography. When the contrast is going to be secreted by the liver, and then the biliary system is getting delineated, it will be indirect cholangiography. Okay, so with this understanding now, can you tell me any indirect cholangiography you know? Any indirect cholangiography you can, if name. Very good. MRCP, magnetic resonance cholangiopancreatography. Very good. IDA scan. The radioisotope is given, and then it is secreted by the liver, and it delineates the biliary channel. Any other? Oral cholecystography, which is also called Graham Cole test. Any other you know? CT cholangiography. These are the indirect cholangiographies we have, we should know. Any direct cholangiography you know? Very good. Percutaneous transhepatic cholangiography. Any other? ERCP. Very good. Endoscopic retrograde cholangiopancreatography. Any other? T tube cholangiogram. These are the various direct cholangiographies we have. Okay, now let us know the theoretical points about these investigations, and then we will understand the clinical part. Okay, first of all, ultrasound. Ultrasound is the first imaging investigation. Ultrasound is the first imaging investigation for evaluation of biliary system. Ultrasound is a first imaging investigation for evaluation of the biliary system. Ultrasound is the investigation of choice for cholelithiasis. And gallstone on ultrasound, you should know, a potential question again, gives a shadow which is called posterior acoustic shadow. Gallstones on ultrasound gives a shadow which is called posterior acoustic shadow. Ultrasound is also investigation of choice for acute cholecystitis. It is also investigation of choice. It is also investigation of choice for chronic cholecystitis. Right? And it can also differentiate gall bladder polyp and sometime carcinoma gallbladder also. Ultrasound is a very good modality, but please note the investigation of choice for this is CT scan. Investigation of choice to categorically differentiate the two things is CT scan. It's a very good modality to know CBD status. What do you mean by CBD status? Whether the CBD is dilated or not dilated. But very important to note, it is not a good modality for cause of CBD dilatation. It is not a good modality for a cause of CBD dilatation. So it can tell you whether the CBD is dilated or not, but it will not be able to tell you what is the reason of this dilatation. So that's an important point, right? Then comes MRCP. MRCP is the investigation of choice for CBD stone. Gallstone is called cholelithiasis. CBD stone is called cholelithiasis. Right? And it is also investigation of choice for biliary leak or stricture. It is also investigation of choice for acute cholangitis. What do you understand by acute cholangitis? What do you understand by acute cholecystitis? Inflammation of gallbladder. And what is cholangitis? Inflammation of the bile duct. It is also investigation of choice for choledochal cyst. Then comes ARCP. ARCP can have a diagnostic advantage, can have a therapeutic benefit also. Can have a diagnostic advantage, can have a therapeutic benefit also. Now, what are the diagnostic advantages? It is a gold standard investigation for CBD stones. It is a gold standard investigation for CBD stones. It is also gold standard investigation for biliary leak. It is also gold standard investigation for polydocal cyst. Okay, now with the help of ERCP, the therapeutic benefit with ERCP are, important point, one can remove CBD stones. One can remove CBD stone. The removal of CBD stone through ERCP is called endoscopic extraction of CBD stone, or it is also called endoscopic, you should note this point, papillotomy or sphincterotomy. Endoscopic, papillotomy or sphincterotomy. One can also put a stent in CBD with the help of ERCP. One can also put a stent, a tube, inside the CBD with the help of ERCP. Papillotomy or sphincterotomy. So one can put a stent in the CBD. One can do a dilatation of CBD also with the help of ERCP. And the most common complication of ERCP, very commonly asked question, is acute pancreatitis. Most common complication of ERCP is acute pancreatitis. Then comes IDA scan. It is also called hepatoscintigraphy. And this investigation, very important, is the most sensitive investigation for acute cholecystitis. And very important point further, failure to visualize gallbladder on IDA scan is diagnostic of acute cholecystitis. It is also most sensitive investigation for biliary leak or stricture. IDA scan is also most sensitive investigation for biliary leak or stricture. Then comes endoscopic ultrasound. endoscopic ultrasound is the most sensitive investigation for lower end CBD stones. So most sensitive investigation for lower end CBD stone, and it is also most sensitive investigation for carcinoma pancreas, for periampullary carcinoma, and also carcinoma gallbladder. So these were the theoretical points about these investigation at one place. Now, how to use these investigations? What is the clinical approach? We will be discussing when we talk about the clinical condition. Okay. So now let us start with polylithiasis. That is gallstone disease. Polylithiasis or gallstone disease. Now, first of all, what are the reasons for having stones in gallbladder? We have to know that what are the reasons, important reasons for formation of gallstones. Now, we don't have to mug up things here. If we know these three basic reasons, every risk factor which I am going to enumerate will be revolving around these three things. What are those three things? One, super saturation of bile. Whenever a bile is super saturated, there will be a risk of stone formation. Second, whenever there is a stasis, then also there will be a stone formation. And third, presence of nucleating factors. Whenever the nucleating factors are present, we don't need to go into the detail of these nucleating factors, but we have to know these two things at least. Now, what is this super saturation of bile, which is also called lithogenic bile? Super saturation of bile, which is also called lithogenic bile. Now, what is this lithogenic bile? Let's understand. What happens is, you all must be aware that cholesterol molecule per se is insoluble in water. So it floats in water. And once it floats in water, it has a very high chances of getting precipitated and forming a stone. So to prevent this, body has an arrangement. What body does, it has this cholesterol molecule, body tries to make it soluble by getting this cholesterol molecule attached by a bile and phospholipid. Bile and phospholipid gets attached to a cholesterol molecule and form a compound called micelle. Bile and phospholipid get attached to cholesterol molecule and form a compound called micelle. So this micelle is soluble in water. So any condition in the body, any condition important, which leads to increased cholesterol in the body or decrease in bile and phospholipid in the body, can lead to precipitation of this cholesterol molecule. And whenever there is any condition where there is increase of cholesterol is there or decrease of bile and phospholipid is there, that is called a supersaturated or a lithogenic bile. Whenever there is increase of cholesterol or there is decrease of bile and phospholipid is there, it is called lithogenic or a supersaturated bile. So anything in the body, if is leading to increase in cholesterol or decrease in bile and phospholipid, there will be stone formation because of that. So on the basis of this, there is an aphorism also for stone formation, that is fat, fertile, female of 40s. 4F. Fat, fertile, female of 40s. So what are the risk factors? If you have a female gender, there will be risk. If you are fat, obese, you have a risk. If you are above 40 years of age, you have a risk. And if you have high estrogen level, means fertile, you have a risk. Then the other risk factors for gallstone disease are high fatty diet. High fatty diet is a risk factor. Oral contraceptive pills or hormone replacement therapy also has a risk. Then pregnancy also has a risk. Then very important to note, small bowel diseases like ileal resection, short bowel syndrome, or even in Crohn's disease, there's a risk. Now, can anyone tell me why in these diseases there is a risk of gallstones? Huh? Presence of why hypersaturation happens? Less absorption of what? If there is a less absorption of fat, there is a part of the bile which get absorbed where? Which small bowel? Ileum. So terminal ileum is a part of the bowel where the bile gets absorbed and go back to the liver, enterohepatic circulation. So any patient who has terminal ileum removed, any patient who has a terminal ileum diseased, any patient who doesn't have a small bowel, there will be a problem in the absorption of bile. And once there is a problem in the absorption of bile, the enterohepatic circulation, the bile will not go back to the liver and the bile will be less in the body. So the reason for small bowel disease leading to stone formation checked in exam is decreased bile. Then primary biliary cirrhosis, alcohol, diabetes mellitus, hemolytic anemia, and infection. These are the important risk factors for gallstones. These are the important risk factors for gallstones. Now, what are the types of stones in gallbladder? Huh? Very good. There is mixed stone. There is mixed stone. There is a pigment stone. Which is the most common stone in gallbladder? The most common stone in gallbladder is mixed stone. But please be very careful here. Checked again in our exam. Most common stone in Asian population if asked. Please be careful. It is a pigment stone. The most common stone in Asian population if asked, it is a pigment stone. And mixed stone is the most common stone, and the major constituent, a question asked, the major constituent of mixed stone is crystalline, cholesterol, monohydrate. Crystalline cholesterol monohydrate is the major constituent of mixed stone, and pigment stones are of two types: black stone and brown stone. Pigment stones are of two types: black and brown. And very important point further to know, all these conditions which I mentioned at the last, these with cystic fibrosis also, these are the conditions which leads to pigment stone formation. And out of all these conditions, infection is the condition which leads to brown stone formation. Rest all leads to black pigment stones. Rest all leads to black pigment stones. Right? Now, then comes, can you tell me what will happen if there is a stone in the gallbladder? What are the consequences of having stones in gallbladder? First of all, patient of gallstone disease may remain asymptomatic without any problem also. What else? One can develop acute cholecystitis because of the gallstones. One can develop chronic cholecystitis also because of the gallstones. One can develop mucocele or empyema of the gallbladder also. One can have a perforation of gallbladder because of the gallstone too. One can also have polycystoenteric fistula also because of the gallstones. One can develop, these are the things they have asked, gallstone ileus also. Perforation होगा तो peritonitis हो जाएगा. Gallstone ileus also. One can also develop carcinoma gallbladder due to gallstones, and one can also develop CBD stones because of gallstones. One can also develop acute cholangitis. one can also develop acute pancreatitis due to gallstones. Acute cholangitis, सीबीडी स्टोन होगा तो जॉन्डिस हो जाएगा ना, अभी करेंगे बात आएगा. Now, once you have a gallstone, now can anyone tell me, once there is a gallstone, what are the treatment options we have for treating gallstones? Lap coli, lap coli तो ऐसे बोल रहे थे, E. coli को. So we have option of medical therapy, we have the option of medical therapy, we have the option of surgery. What is the surgery called? Cholecystectomy. So there is open cholecystectomy, there can be laparoscopy. I asked this question once in a class and I got the answer, cholecystectomy. It is not chole, it is chole. So that means there is open chole and there is a laparoscopic chole also. And out of open and laparoscopic chole, which one you will prefer? Preferred is laparoscopic chole. Then we also have an option of ESWL. What is ESWL? What is ESWL? Extracorporeal shock wave lithotripsy. Extracorporeal shock wave lithotripsy. Extracorporeal shock wave lithotripsy. Right? And we also have an option of watchful waiting. We also have an option of watchful waiting. In a medical therapy, we have what medical therapy we give? Ursodeoxycholic acid. Ursodeoxycholic acid is the medical therapy we have. Now, we don't need to go into the indications of these various therapies. We just need to know more often than not, we prefer cholecystectomy, and in that we prefer a laparoscopic cholecystectomy. Okay. Now comes a very important question. Most common presentation of a patient of gallstone disease. Can anyone tell me what is the most common presentation? Most common presentation is asymptomatic, incidentally found. What is this asymptomatic incidentally found means? You are doing a ultrasound for some other reason and you came across stones in gallbladder. You are doing ultrasound for some other reason and you came across stone in the gallbladder. Now listen to this very carefully. Imagine a female has come to you with a complaint of dysmenorrhea and menorrhagia, right? You advised her ultrasound. On ultrasound, you found that there is a fibroid uterus and there is also gallstone in gallbladder. And when you inquired from her that whether she ever had a pain in her upper abdomen in past, she says, I never had pain in my upper abdomen in past. So she is a female who has incidentally found a gallstone. So what advice are you going to give to her for these gallstones? What is operable? क्या डाइट चेंज करने से स्टोन चला जाएगा? स्टोन तो बन गया, पहले चेंज कर लेते तो बेटर था. Answer is observation, watchful waiting, watchful waiting. But there are times even when the patient is asymptomatic of gallstone disease, we are still supposed to offer cholecystectomy. And when we offer a cholecystectomy without patient being having any symptom in an asymptomatic gallstone disease, that cholecystectomy is called prophylactic cholecystectomy. That cholecystectomy is called prophylactic cholecystectomy. Now, what are the indications of prophylactic cholecystectomy? Very, very important for us. A potential question in exam. The indications of prophylactic cholecystectomy are stone more than 3 centimeter in size, not 3 millimeter. More than 3 centimeter in size. Second, patient having gallstone pancreatitis. Patient having gallstone with polyp. Patient having porcelain gallbladder. What is porcelain gallbladder? Calcified gallbladder. Porcelain gallbladder is calcified gallbladder. Or the patient has anomalous pancreatico biliary junction, or the patient has hemolytic anemia, or the patient is immunocompromised, or suppressed, or gallstone found incidentally during laparotomy or laparoscopy. This is a potential question in an exam, clinical question. They may ask you that the surgeon is doing a laparoscopic appendectomy for interval appendectomy. We'll be talking about that. And on putting in a laparoscope, he could see stones in gallbladder. What should he do? Remove gallbladder. Okay. Then 9. When immediate healthcare facilities are not available. Patient is residing in a place where the immediate healthcare facilities are not available. This per se is for now. In present time, there is no place where we don't have an immediate healthcare facility available. So this indication is specifically for the astronauts, those who are going to space. So if you are planning to go to space, leave your gallbladder here. If you have a stone in that, obviously. Now, so these are the indications of prophylactic cholecystectomy. Even when the patient is asymptomatic, we have to remove gallbladder, right? Then we all know by now that laparoscopic cholecystectomy is preferred over open cholecystectomy. But then there are contraindications for laparoscopic cholecystectomy also. What are the absolute contraindications for laparoscopic cholecystectomy? The absolute contraindications are: 1, patient unable to tolerate general anesthesia. If the patient is unfit for general anesthesia, patient is unfit for laparoscopic procedure. Remember, any patient who is unfit for general anesthesia is unfit for any laparoscopic procedure. Laparoscopic procedure is done in general anesthesia only. Second, patient with bleeding disorder. Patient with bleeding disorder. Third, लैप्रोस्कोपिक में ब्लीडिंग कम होता है, बट ब्लीडिंग होने के बाद कंट्रोल बड़ा मुश्किल होता है, इसलिए. ओके, देन suspicion of malignancy if there, again one should not do a laparoscopy. The relative contraindications are previous upper abdominal surgery, cirrhosis, portal hypertension, and COPD. These are the relative contraindications for laparoscopic cholecystectomy. Okay, now, most common presentation of a patient of gallstone disease is asymptomatic, right? But if asymptomatic is not there in our choice, then the most common symptom, if they ask, most common symptom is biliary colic. If biliary colic is also not there, then acute cholecystitis. So most common symptom if asked, it is biliary colic. And if biliary colic is not in our choice, then the symptoms of acute cholecystitis will be the most common symptom. Now, let us talk about acute cholecystitis. Very important discussion it is. Acute cholecystitis can be a calculous cholecystitis, can be a acalculous cholecystitis. Means acute cholecystitis can happen because of the stone in the gallbladder. Acute cholecystitis can happen without the stone in gallbladder also. More common is calculous cholecystitis. Right? Now, this is very important and this can be a clinical question to you in exam too. So please be careful. In a acute acalculous cholecystitis. Okay, we'll come back to this acalculous cholecystitis later. Let us first know that how a patient of acute calculous cholecystitis is going to present to us. Once we understand that, then only we will be able to understand acalculous cholecystitis per se. So let us first talk about acute calculous cholecystitis. Okay. Now, more common than calculus and acalculous, more common is calculus, we know. Now, how does a patient of acute calculus cholecystitis is going to present? The most common presentation of that patient will be, can you tell me? Pain in a right upper abdomen. Patient will come to you with pain in right upper abdomen, but very important, the characteristic symptom. When we say characteristic symptom, this will be a key point. Characteristic symptom का मतलब होता है when it is there, provided it is there in that particular condition only. So if this is provided to you in any given question, it means the examiner is talking about acute cholecystitis only. Okay, so what is that symptom? Pain right upper abdomen, radiating to right shoulder or inferior border of scapula. Pain right upper abdomen, radiating to right shoulder or inferior border of scapula. Right? Patient can also come to us with vomiting. Patient can also come to us with fever. On examination of these patients, you will find tenderness in right hypochondrium. Tenderness in right hypochondrium. And there is a classical sign present called Murphy's sign. What is Murphy's sign? Murphy's sign is sudden catch in breath, sudden catch in breath while palpating right hypochondrium during inspiratory phase of respiration. You are palpating right side. Once you reach right hypochondrium during inspiratory phase, when you palpate it here, the patient suddenly catches his breath. This is called Murphy's sign. And there is another sign which can also be there called Boas's sign. What is Boas's sign? Boas's sign is area of hyperesthesia between 9th to 11th rib on the right side posteriorly. Area of hyperesthesia between 9th to 11th rib on right side posteriorly. If these signs are provided, again it is diagnostic of acute cholecystitis. Okay, now the investigation of choice is ultrasound. We know that. Now, what do we get in ultrasound? Important point. These findings are important. What ultrasound findings will get in acute cholecystitis we should know? See, we have to understand why does a acute cholecystitis happens. Once we understand why acute cholecystitis happens, we can make out the ultrasound findings also. This is gallbladder. Why is it like this? That some of the patient of gallstone disease remain asymptomatic and we are not doing anything in them also. And why some of the patient of gallstone disease are developing problems. Every problem in gallbladder due to gallstones stems from this. What happens is one of the stones from the gallbladder migrates and obstructs the opening of the cystic duct. This is the reason for acute cholecystitis. Now, what happens now? You can appreciate that no more bile is going to go in, no more bile is going to come out also. So whatever bile is there will get pent up inside. We know that. And we also know that the function of gallbladder, what are the functions of gallbladder? Storage of bile. Second, concentration of bile. Third, secretion of mucus also. Gallbladder secretes mucus also. So now no more bile is going in, no more bile is coming out. And mucus is still being secreted, right? So what will happen? The gallbladder will start distending, right? And this is the rule of nature, remember. ये हमारी common day-to-day practice में भी if you see, you can find. If there is a drain, if that drain is flowing, even if that drain is containing a dirty thing, fecal matter even, if that drain is flowing, it never smells. If it is flowing, but movement, there is a block. Even if you keep normal water blocked, after some time, it starts smelling. So the same thing happens in our body, that if any organs secretions get blocked, the bacteria present in the wall of that organ start proliferating and leads to the inflammation and then infection. So what happens is the secretions of the gallbladder got blocked and now the gallbladder will get infected. So this leads to acute cholecystitis. Okay, now, so what ultrasound finding we get in this patient? Please correct me if I'm wrong. A patient will have distended gallbladder. Yes or no? Right? Now, since there is a inflammation of the gallbladder here, and we all know that whenever inflammation happens, there is edema also there. So the cells of the gallbladder wall will get edematous. Agreed? So when the cells of the gallbladder wall get edematous, what will happen? The gallbladder wall gets thickened because of the edema, and some of the edema fluid from the gallbladder will leak out also. The cells will leak out some of the fluid, so there will be a pericholecystic fluid also. So if you find ever these three findings on ultrasound, patient is having acute cholecystitis. Now, if along with this in your given question, it is mentioned that there are posterior acoustic shadows also, so that means it is acute calculus cholecystitis now. So that means in acute acalculous cholecystitis, you will just have these three findings. So you should be able to make out on the basis of ultrasound that what problem the patient has. Understood? Now, coming on to very important point further. Correct me again if I'm wrong. Acute cholecystitis. Can I say that it's an acute infective GI condition?
Yes.
Yes. So what will be the first line of management? IV fluid. Sagar. Milper orally, IV fluid, IV antibiotic, and IV anti-inflammatory drugs. So you will immediately start this. You will immediately start this. Right? Now, earlier what we were doing in acute calculus cholecystitis, this treatment most of the time is sufficient. Most of the time, the patient of acute calculus cholecystitis improves on this treatment. So what were we doing earlier? Since the patient was improving with this treatment, earlier it was said that we should offer, once the patient improves with acute cholecystitis with this treatment, it was said earlier that we should offer interval cholecystectomy, laparoscopic cholecystectomy after 6 to 8 weeks. पहले कहा जाता था कि ये ट्रीटमेंट शुरू करो और ये ट्रीटमेंट most of the time since improves the patient, so we should discharge this patient and tell them to come back after 6 to 8 weeks for interval removal of the gallbladder. Now they say that once a patient of acute cholecystitis comes to us, calculus cholecystitis comes to us, we should start this treatment. And if the patient is coming to us in 48 to 72 hours, only if the patient is coming within 48 to 72 hours, this 48 to 72 hours is from the time of patient's symptom, not from the time of admission. Right? So if the patient comes to us in 48 to 72 hours, we should offer to these patients early laparoscopic cholecystectomy. Early laparoscopic cholecystectomy. Now, important point to note in this is, which is very important for us to understand also, this early laparoscopic, there are two types of operation theater we have. One is elective operation theater, another is the emergency operation theater. So this early laparoscopic cholecystectomy, we are not going to do in emergency operating room. We will be doing it in a elective operating room. This is important. So, emergency operating rooms operate 24/7, right? So emergency operation room में आपको पहले से कोई slot book करने की जरूरत नहीं होती. आपको emergency है तो आपको immediately operation theater में लिया जाएगा. Elective operation theaters में we have to understand this. Elective operation theaters में every surgical unit, you all must be aware, this is not only in India, everywhere it is like this, that every surgical unit has a designated days of elective operating room, that they will be given this day, that you can do elective cases on these days, right? So we have a register where we maintain that these are the patients we will be placing on this very particular day of our elective work. So now this patient is going to come to us in emergency. Please understand this. This patient is coming to us in emergency and we are planning a early laparoscopic cholecystectomy which is to be done in an elective work, right? So this patient was not planned. There were patients, we have a register where we have already given the date to the patients and they will be coming to us on that day. This patient has come to us randomly, suddenly, and we have to put this patient in an elective operating room now. So what we have to do, we have to remove one of the case which is already placed in the elective operating room in the coming OT and put this patient. So what I'm trying to convey through this was a question also asked, that this early laparoscopic cholecystectomy is not going to be done in emergency operating room. This will be done in an elective operating room by in the coming OT, whatever the coming day which you are coming in your list, in your day allotted, and you have to remove one of the case from the elective OT to place this case. So this was a question asked that a patient has come with features of acute cholestasis, clinical presentation was there, and then you were asked, when are you going to do this surgery? You will do this surgery in emergency operating room. You will remove one case from the elective OT and do it in the coming OT list, or you will give this patient a date of elective OT. So answer is, you will remove the case in the elective OT in the coming OT list and put this case. Okay, so we should know this clinical part in a acute cholecystitis. Now, if the patient is coming to us in more than 72 hours, we will continue with this treatment and offer interval cholecystectomy after 6 to 8 weeks. समझ आया? Now, in acalculous cholecystitis, very important point. उसका भी करना है, मतलब इमरजेंसी इलेक्टिव में होती नहीं है, इलेक्टिव होता है। ये अभी हमने कैलकुलस कोलिसिस्टाइटिस की बात कर रहे थे ना, ठीक है? सो दिस वाज अबाउट अ कैलकुलस कोलिसिस्टाइटिस। अरे अपेंडिक्स, एक्यूट अपेंडिसाइटिस इलेक्टिव ओटी में होता ही नहीं है, तो इमरजेंसी में होता है। इमरजेंसी में होती है, तो जो इलेक्टिव में हो रहा है उसका इमरजेंसी है ही नहीं, ठीक है ना? नाउ चले आगे। नाउ एक मिनट क्या तुम बताओ, अगर पेशेंट 48 टू 72 आवर्स के बीच में आया तब तो ये, अगर उसके बाद आया तो ये, राइट? नाउ एक्यूट acalculous cholecystitis, अब ये बहुत इंपॉर्टेंट क्लिनिकल प्रोफाइल होगी एंड वी हैव टू नो दिस क्लिनिकल प्रोफाइल। acalculous cholecystitis इज नॉट अ कॉमन थिंग। acalculous cholecystitis कॉमन नहीं है। acalculous cholecystitis happens usually in patients who are in ICU. जो पेशेंट ऑलरेडी सिक होते हैं, those patients who are already sick, who are in ICU for some other reason, किसी और कारण से these patients are in ICU and they are being managed, they may develop suddenly acalculous cholecystitis also. So what will be the profile of this patient provided to you? You will be told that the patient was in ICU for some condition which is XYZ, any condition that can be, and you will be told that now suddenly patient was doing well in ICU. Now suddenly the patient started deteriorating and complained of pain in his abdomen. When the ultrasound of that patient was done, you found this. So you should, if this profile of the patient is there, you can make out that this is a acalculous cholecystitis. And the treatment of acalculous cholecystitis is immediate cholecystectomy. Emergency cholecystectomy. Immediate मतलब emergency, right? But sometimes these patients' conditions is such, ICU में patient है, तो हो सकता है कि patient की condition ऐसी हो कि आप जनरल एनेस्थीसिया दे ही नहीं सकते, उसको सर्जरी कर ही नहीं सकते, क्योंकि आईसीयू के पेशेंट्स आर यूजुअली सिक. सो इफ यू कांट डू दिस, व्हाट वी डू अ परक्यूटेनियस cholecystectomy. Percutaneous cholecystectomy. Ostomy, making an opening and leaving it open. So what we do in this is a gallbladder which got the inflammation. तो घूम गया. So there was a gallbladder which is distended like this because of the inflammation. So what we will do, we will put a drain in the gallbladder from outside percutaneous ultrasound की guidance में we will put a drain in the gallbladder and let the drain be out on the abdominal wall. Let that drain be out on the abdominal wall. So what we have done, we have opened the gallbladder indirectly on the abdominal wall. So it is called percutaneous cholecystostomy. Percutaneous cholecystostomy. क्या होगा? क्लिनिकल प्रेजेंटेशन सेम होगी, बट आईसीयू वाला पेशेंट आपको बता नहीं पाएगा कि मेरे को यहाँ पे पेन है. आपको एग्जामिनेशन पे टेंडरनेस मिलेगा, आपको यूएसजी में फाइंडिंग मिलेगा. हो सकता है आपको ये ना बोला जाए कि पेशेंट को आईसीयू का पेशेंट है और उसको पेन हो रहा है, बट आपको ये बताया जाए कि ऑन एग्जामिनेशन पेशेंट के टेंडरनेस है राइट हाइपोकॉन्ड्रिया में, अल्ट्रासाउंड में ये है. तो क्या हो सकता है? पेशेंट डिटेरियोरेट होने लग गया ना सडनली, अल्ट्रासाउंड करेंगे, पता लगाएंगे क्यों डिटेरियोरेट हो रहा है. Gallbladder, राइट. सिस्टिक डक्ट से तो बाहर निकल ही नहीं रहा सामान, राइट. सो दिस वाज अबाउट एनी डाउट. चलें आगे. So this patient, imagine a patient comes to us with an acute calculus cholecystitis. Patient comes to us with acute calculus cholecystitis, but came to us after 72 hours. What will you do? And then interval laparoscopy. So if I ask you a single liner question now, which will not come in present type of exam we are having. If I ask you, what is the treatment of choice for acute cholecystitis? What is a treatment of choice for acute calculus cholecystitis? We have to mention early laparoscopic cholecystectomy. Early, and if this question was asked previously, if it was asked previously, the answer would have been conservative management. Answer earlier was conservative management. Now is early laparoscopic cholecystectomy. Now imagine a patient has come to you. Imagine a patient has come to you after 72 hours. Right? And you advise this patient elective laparoscopic cholecystectomy after 6 to 8 weeks. Patient didn't get it done. अब patient के पीछे तो भागेंगे नहीं, figure out, right? So this patient who didn't get a cholecystectomy done after acute attack is now a chronic cholecystitis patient. This is now a chronic cholecystitis patient with us. Now, how will this patient come to you? This patient, how will this patient come to you? This patient comes to you with a off and on biliary colic. Off and on biliary colic. Patient can also have dyspepsia. On examination of this patient, On examination of this patient, there will be no abnormality. On examination of these patients, there will be no abnormality. तो अब कैसे पता लगेगा? अगर एग्जामिनर आप पे बहुत ज्यादा खुश है, जो होता नहीं है ज्यादातर टाइम, तो एग्जामिनर कैन टेल यू दैट द पेशेंट हैज अ previous attack in the past, which patient, when patient was told to get a cholecystectomy done, but the patient didn't get it done. So then that way you will know that this is a patient of chronic cholecystitis. So if the examiner is not telling you this and just tells you that the patient is coming to you with the pain in the right upper abdomen, off and on, and with a complaint of dyspepsia, on examination there is nothing. So how will you know that this is a patient of chronic cholecystitis? So even if, listen to this carefully, even if the patient doesn't tell us that whether there was a previous attack of cholecystitis in the past or not, we can still make out that the patient must have had the previous attack. How? Through ultrasound. Because when we do ultrasound of an asymptomatic gallstone disease patient, the ultrasound or chronic cholecystitis, देखो, pain in right upper abdomen can be because of many reasons. And ultrasound, if you do of a patient, say for example, a patient has a gastritis. Just imagine a patient has a gastritis. Patient can have a pain in the epigastric or right upper abdomen. Patient can have dyspepsia also, right? And if you do ultrasound in that patient, you may find a asymptomatic gallstone disease also. How it will be asymptomatic then? तो कैसे पता लगता है अल्ट्रासाउंड से कि ये जो पेशेंट है ये एसिम्प्टोमेटिक गॉलस्टोन डिजीज वाला पेशेंट है या ये पेशेंट का गॉल ब्लैडर में प्रॉब्लम है? सो अल्ट्रासाउंड कैन टेल अस हाउ what ultrasound finding will be there in a patient of chronic cholecystitis. Okay. देखो ये chronic cholecystitis का patient, आने दो भाई, chronic cholecystitis का patient will be the one who must have had a previous attack of acute cholecystitis. Every inflammation is followed by a fibrosis. We know that. And gallbladder, we all know, is a pear-shaped organ. Gallbladder is a pear-shaped organ. So if you find a posterior acoustic shadows in a gallbladder which is pear-shaped, having no other finding, it is an asymptomatic gallstone disease patient, incidentally found gallbladder. But in a chronic cholecystitis patient, you can appreciate once acute episode has happened, the gallbladder will be deformed because the wall got fibrosis. So gallbladder wall will be deformed, right? And this will be a deformed gallbladder. Now, there is no acute inflammation at this time since, so it will be deformed gallbladder, first of all, and there will be posterior acoustic shadows in it. There will be posterior acoustic shadows in it, and since at this moment, patient doesn't have any acute problem, so there will be no increase in wall thickness also. Please appreciate these findings. And there will be no polycystic fluid also. There will be no pericholecystic fluid also. So if you get these findings on ultrasound, it is diagnostic of chronic cholecystitis. Even the patient doesn't tell you that there was a previous attack. With these findings, you can make out that patient must have had the problem previously also. In an asymptomatic gallstone disease patient, you will get a normal shaped gallbladder with everything normal, just a stone inside, posterior acoustic shadows. हाँ? किसने बोला नहीं मिलता? कहाँ जाता है गॉलब्लैडर? नहीं तो मिलता है, क्यों नहीं मिलेगा? सब मिलता है यार, सब मिलता है, डोंट वरी। ढूंढने पे भगवान मिल जाते हैं। Right? So this is a patient of chronic cholecystitis, and the treatment of choice for chronic cholecystitis is that will not do, right? चलो हो गई नहीं ये कैलकुलस, right? Then a treatment of choice for chronic cholecystitis is elective laparoscopic cholecystectomy, and a patient of mucocele or empyema gallbladder will also present to us with features of chronic cholecystitis only. A patient of mucocele and empyema gallbladder will also present to us with features of chronic cholecystitis only, and the treatment of empyema or mucocele of gallbladder also is elective laparoscopic cholecystectomy, right? And then comes perforation gallbladder. The most common site of gallbladder perforation is fundus. Most common site of gallbladder perforation is fundus, right? And can you tell me, this is a gallbladder which got perforated. So there is a gallbladder which got perforated at fundus. So now, how will a patient of gallbladder perforation is going to present to us? Pruritus? Patient will present to us. बाइल अगर गॉलब्लैडर परफोरेट हो जाएगा तो पेरिटोनियल कैविटी में क्या आ जाएगा, और बाइल आ जाएगा पेरिटोनियल कैविटी में तो क्या हो जाएगा? इन्फ्लेमेशन ऑफ व्हाट? तो क्या हो जाएगा? Patient will present to us with signs, symptoms of peritonitis. Now, what are the symptoms of peritonitis here? What will be the symptoms here? Tell me. Severe symptom. Severe continuous type of stabbing, pain in whole abdomen or generalized abdomen. What else? Distension. What else? Vomiting. What else? Obstipation. भूल गए? कल ही पढ़ा है, कल ही नहीं पढ़ा था? On examination, you will have tenderness, you will have guarding, तुम बताओ क्या है, इतने अच्छा तो लिखा उसने, रिजिडिटी, डिस्टेंशन लिखा है टाइम्स रोमन में। ठीक है, now how will you know that this time this is a gallbladder perforation leading to peritonitis? Pain starting in the, this is not right, this is left. So pain starting in right upper abdomen and then getting generalized. Now what will be your immediate next step? Amputation? It will be nil per orally, IV fluids, IV antibiotic, and IV anti-inflammatory drugs. And the first investigation will be ultrasound, while the most sensitive investigation here will be CT scan. So this is what I told you yesterday also. Yesterday, since we had a suspicion of a peptic perforation leading to peritonitis, so we did chest X-ray as our first investigation. Here, in this given patient, since we have a suspicion of a biliary problem, because by virtue of patient pain starting in the right upper abdomen and then getting generalized, so our first investigation is ultrasound. So you can see here, you have already written that information in your theoretical points, that ultrasound is the first imaging investigation. Remember, as a rule, this will help you in solving clinical questions. Whenever you have any biliary pathology suspicion, the first investigation is always going to be, the imaging investigation is always going to be, as a rule, it will be ultrasound. Okay. Now, how will you manage the treatment of gall bladder perforation? Is exploratory laparotomy. Is exploratory laparotomy with, we will not do cholecystectomy here. We will do a cholecystostomy, not cholecystectomy. Right? We will put a drain in the gallbladder and let that drain be out from the abdominal wall, which is called cholecystostomy. Which is called cholecystostomy. Laparoscopy नहीं है, laparotomy है. Laparotomy means opening the abdomen, then closing it. Okay, then comes polycystoenteric fistula. Polycystoenteric fistula. The most common site of this polycystoenteric fistula is with duodenum. Most of the time, this fistulous communication happens with duodenum, followed by colon. Most of the time, this fishless communication happens with the duodenum followed by colon. So this is what happens in this condition. This is what happens in a polycystoenteric fistula. Most commonly, this fishless communication is there with the duodenum. The first investigation here also is ultrasound. Investigation of choice here is MRCP. And the treatment of choice for this is cholecystectomy with excision of the fishless tract with repair of the organ with which there is a fistula. Cholecystectomy with excision of the fishless tract with repair of the organ with which there is a fistula. Right? Then comes gallstone ileus. Now, what is this gallstone ileus? A very important point and very important scenario. Gallstone ileus is an acute intestinal obstruction. Acute intestinal obstruction due to gallstones. Gallstone ileus is an acute intestinal obstruction due to gallstone. Now, please try to understand this. Imagine there is a gallbladder. There are stones in the gallbladder. Right? Now, acute cholecystitis क्यों हो रहा था? Let's see. Gallstone आया, सिस्टेट रख के फंस गया. आपने कंजर्वेटिव ट्रीटमेंट दिया. कंजर्वेटिव ट्रीटमेंट से पेशेंट वर इंप्रूविंग. Why were they improving? What was happening and why were they improving? And how we are waiting for, why we are waiting for 6 to 8 weeks? These are the questions which should come in your mind. आपने कंजर्वेटिव ट्रीटमेंट शुरू किया, इन्फ्लेमेशन थी, यहाँ पे ये इन्फ्लेमेशन थी, राइट? आपने पेशेंट को निल पर ओरली किया, आईवी एंटीबायोटिक शुरू की, एंटी इंफ्लेमेटरी ड्रग शुरू की. The moment you start anti-inflammatory drugs and the antibiotic, this inflammation subsides. The moment this inflammation subsides, you can appreciate here. Now, this stone was stuck because of the inflammation. The moment inflammation subsides, the stone got free. The moment the stone got free, this stone, most of the time, what happens? Falls back. And moment this stone falls back, the passage got opened up. And moment the passage gets opened up, everything which was stagnant got a vent to release and the problem got solved. Right? This was the problem happening and this is how the problem got sorted with a conservative treatment. Right? Now, most of the time what happens, the stone falls back. Right? But the stone can fall to this side also. So once the stone falls to this side, it will lead to a CBD stone. Right? So you can appreciate that acute cholecystitis होगा patient को आपने conservative treatment दिया, patient improve हो गया, but इस बार इस कारण से हुआ. Patient तो improve हो जाएगा जैसे stone CBD में आएगा, but CBD में stone आने से एक और problem हो सकती है. ये stone tumble करेगा down और एम्पुल ऑफ वेटर पे आके हो सकता है ब्लॉक कर दे, और अगर ये ब्लॉक कर देगा तो पेशेंट को जॉन्डिस हो जाएगा, राइट? सो दिस इज अ सीबीडी स्टोन लीडिंग टू अ ऑब्स्ट्रक्टिव जॉन्डिस. नाउ व्हाट टू डू अबाउट दिस सीबीडी स्टोन विल टॉक अबाउट लेटर, राइट? दिस इज ऑल्सो वन ऑफ द पॉसिबिलिटी कि ये स्टोन आया, यहां से टंबल हुआ, एम्पुल ऑफ वेटर पे आया और एम्पुल ऑफ वेटर से भी निकल गया, हो सकता है, राइट? अब ये स्टोन एम्पुल ऑफ वेटर से निकल गया, think about it and tell me that can this stone ever block the lumen of the intestine? For this stone, the lumen of this stone has negotiated ample of water. So this stone, for this stone, the lumen of the intestine is now like a gateway of India. This stone can never obstruct the lumen of the intestine, right? But gallstone ileus is an acute intestinal obstruction due to gallstone. So how a gallstone is obstructing the lumen of the intestine? This can only happen if the patient has this. If the patient has a cholecystoenteric fistula, the big stone can come out of this fistula depending on how big the communication is. So when there is a big communication, the big stone may come out, and when this big stone comes out, they may obstruct the lumen of the intestine. So what I am trying to convey through this is gallstone ileus is always a sequelae of cholecystoenteric fistula, right? And the most common site, very commonly asked question, the most common site of infection where the stone blocks the lumen of the intestine, checked in exam again, is terminal ileum. The most common site of infection of gallstone in gallstone ileus is terminal ileum, right? Now, this patient of gallstone ileus is going to present to us with features of acute intestinal obstruction. This patient of gallstone ileus is going to present to us with features of acute intestinal obstruction. What are the features of acute intestinal obstruction? We will talk about when we talk about intestine. At this time, you just need to know a patient is going to come to us with features of acute intestinal obstruction. What are those features? We will discuss, right? And one should know here that a patient of gallstone ileus can also have a triad called Wriggler's triad. A patient of gallstone ileus can have a triad called Wriggler's triad. So what is Wriggler's triad? Small bowel obstruction. This was a recent NEET question. Small bowel obstruction, pneumobilia. What is pneumobilia? Presence of air in the biliary tree. And ectopic gallstone. This is Wriggler's triad. And patient of gallstone ileus is going to present to us with features of acute intestinal obstruction. What are those features? We will be discussing. And the first investigation here is X-ray abdomen, erect and supine, and investigation of choices for gallstone ileus, checked many times in exam, is CT scan. First investigation is X-ray abdomen, erect and supine. Investigation of choice is CT scan, right? And the treatment of choice for gallstone ileus is exploratory laparotomy with relief of obstruction only. Treatment of choice for gallstone ileus is exploratory laparotomy with relief of obstruction only. देखो क्या है, ये यहां से स्टोन निकला और ये स्टोन इंटेस्टाइन में ऐसे टंबल किया और यहां पे आके फंस गया। ठीक है, अब इस आ रहा हूं मैं, वेट करो। अब इस सिनेरियो में हमारे पास दो ऑप्शंस हैं। लिसन टू दिस पॉइंट केयरफुली। In treating a gallstone ileus, I have two options. In treating gallstone ileus, I have two options. One option is I open this abdomen, exploratory laparotomy, give incision on the intestine, open intestine, remove the stone and close it. What will this be called when I open intestine and remove the stone and close it? अरे कौन सा टॉमी? Enterotomy. Enterotomy. Right? So one option is I open intestine, remove the stone and close it. The second option I have is I do enterotomy, remove the stone and do cholecystectomy with excision of the fistula and repair of the organ in the same sitting. दो ऑप्शन है मेरे पास। एक ऑप्शन है कि मैं सिर्फ ऑब्स्ट्रक्शन को रिलीव करूं अभी, और ये कोलिसिस्टेक्टमी और एक्सीजन ऑफ द फिस्टुला ट्रैक और जो कोलिसिस्टेंटिक फिस्टुला बना हुआ है उसको सेम सिटिंग में, सेम सर्जरी में ट्रीट करूं। और दूसरी ऑप्शन है दैट आई जस्ट डू रिलीफ ऑफ द ऑब्स्ट्रक्शन एंड डू ट्रीटमेंट ऑफ कोलिसिस्टेंटिक फिस्टुला ऑन अ लेटर डेट। These are the two options I have. As per the latest guideline, the preferred one is to just relieve the obstruction at this moment, do cholecystectomy and excision of the fistula tract and repair of the organ on a later date. So if you are asked, what is the treatment of choice for gallstone ileus? If both the options are there, pick this option. फिर से आ सकता है। तो सर्जन है, दिमाग भी लगाते हैं। मेडिसिन वालों ने ठेका थोड़ी लिया दिमाग लाने, हम भी लगाते हैं दिमाग। तो हम क्या करते हैं, जब ये स्टोन के लिए एंट्रोटमी करते हैं तो स्टोन ही निकाल देते हैं और गॉल ब्लैडर से सारे स्टोन्स को मिल्क करते हैं और यहां से निकाल लाते हैं। और बाद में फिर कोलिसिस्टेंटिक फिस्टुला को बाद में। सो मेडिसिन वालों ने दिमाग लगाने का ठेका नहीं लिया, वो दिमाग ही लगाते हैं सिर्फ, और इतनी लंबी सारी लिस्ट ऑफ इन्वेस्टिगेशन दे देंगे। फीवर के लिए खूब सारी इन्वेस्टिगेशन कराते हैं और उसके बाद बोलते हैं पायरेक्सिया ऑफ अननोन ओरिजिन। Right? So this was about gallstone ileus. Then comes CBD stones. हाँ, तो रह गया तो क्रॉनिक कोलिसिस्टाइटिस होगा, इसको तो करेंगे बाद में कोलिसिस्टाइटिस। अगर अभी नहीं कराई इसने तो, अगर कंजर्वेटिव मैनेजमेंट से आपने मैनेज किया है पेशेंट को, स्टोन गॉल ब्लैडर में गिर गया, तो तभी तो हमने इसको इंटरवल कोलिसिस्टेक्टमी बोला 6 से 8 वीक्स में। एक बार गॉल ब्लैडर में इन्फ्लेमेशन हो गया, पेशेंट इज अ सिम्प्टोमेटिक गॉलस्टोन डिजीज पेशेंट। आपको गॉल ब्लैडर रिमूव करना। Now CBD stones. There are two types of stones in CBD. हाँ, एक मिनट। कौन सा कंटेंट? इंटेस्टाइन का कंटेंट भी जा सकता है गॉल ब्लैडर की तरफ, तो जा सकता है, तो तभी तो उसको ट्रीट करते हैं। कोलिसिस्टेंटिक फिस्टुला को तभी तो ट्रीट कर रहे हैं, करेंगे, राइट, बट नॉट इन द सेम सर्जरी। CBD stone. Now CBD stone can be there can be two types of stones in CBD. Primary CBD stone and secondary CBD stone. What is primary and what is secondary? Primary, which is formed in CBD. Secondary, which is dropped down from gallbladder. Primary, which is formed in CBD either due to stasis or due to infection. Now, can you tell me which is more common? Two choices. Secondary CBD stones are more common than primary. Now, can you tell me what is the most common secondary CBD stone? The one which is more common in gallbladder. The one which is more common in gallbladder, that is mixed. And the most common primary CBD stone is pigment stone. So if I ask you now, what is the most common stone in CBD? What will that be? Because secondary stones are more common than primary. Now, please try to understand what I'm going to discuss now, because this understanding is a key. Most of the time, ये scenario होगा. Agreed? या फिर ये भी हो सकता है. Agreed? क्या फर्क है दोनों? एक में कंप्लीट ब्लॉक हो रखा है सीबीडी का, एक में पार्शियल है. Agreed? So correct me. This patient will come to me with the features of acute, why stagnation. Whenever stagnation of the content happens, proliferation happens and the infection develops. So this will come to us with acute cholangitis, right? So we are talking about this scenario first. Means CBD stone without cholangitis. CBD stone without cholangitis. Now please इस बात को समझने की जरूरत है, और ये क्वेश्चन किसी भी तरह से फ्रेम होके आ सकता है. एंड विद दिस प्रेजेंटेशन व्हिच आई हैव शोन यू, you should be able to make out what is happening. Okay, now again, what will be the presentation of this patient to us? The most common presentation of this patient of a CBD stone will be biliary choling, right? Now in this scenario, the patient will have jaundice, but there will be a mild jaundice. Agreed? Agreed? Yes or no? Yes, sir. There will be mild jaundice, right? What kind of jaundice will it be? There are three types of jaundice: pre-hepatic, hepatic, and post-hepatic. It's a post-hepatic jaundice. Post-hepatic jaundice, it will be. Agreed? Right? So this patient will have a post-hepatic type of jaundice. Again, in this bilirubin of this patient will be raised, but mildly raised. Agreed? Not grossly raised, because there is a passage to the bile, not a complete obstruction. Agreed? And what type of bilirubin will there be raised? There will be a conjugated or डायरेक्ट बिलिरुबिन रेज्ड। ना कोई मुझे बताएगा कि कॉन्जुगेटेड बिलिरुबिन किसी और कंडीशन में भी रेज्ड होता है? What other condition can lead to an increase in conjugated jaundice? There are three types of jaundice: pre-hepatic, hepatic, and post-hepatic. Pre-hepatic में कौन सा jaundice बढ़ता है? Hepatic में, hepatic और post-hepatic में conjugated jaundice is raised. तो अब मुझे कैसे पता लगे patient has a conjugated jaundice, conjugated bilirubin raised? So how will I know that this is an obstructive jaundice? Alkaline phosphatase. अगर alkaline phosphatase raised है and conjugated bilirubin raised है, so it means it's an obstructive jaundice, right? तो अगर आपके पास इस कंप्लेंट के साथ पेशेंट आएगा तो सबसे पहले आप क्या करोगे? पेशेंट आपके पास पेन एब्डोमेन के साथ आया, राइट अपर एब्डोमेन एंड जॉन्डिस, अल्ट्रासाउंड, द फर्स्ट इमेजिंग इन्वेस्टिगेशन इज ऑलवेज अल्ट्रासाउंड, वी नो। आपने अल्ट्रासाउंड किया, यू फाउंड गॉलस्टोन्स, and again let me know, in this CBD will be dilated or not dilated? Will be dilated but not majorly dilated. Means if a normal diameter of the CBD is 4 to 6 mm, it will be around 7 or 8 mm. Agreed? Right? So as a rule remember, and this will be checked in your exam also, this was checked in a recent exam also. Any patient if has jaundice clinically, which is obstructive clinically, or having direct bilirubin raised, or alkaline phosphatase raised, or CBD dilated on ultrasound. If any of these are there in your given patient, किसी भी पेशेंट में इनमें से कुछ भी है, आफ्टर अल्ट्रासाउंड you are supposed to do MRCP. ठीक है? Or in other words, this also you should engrave in your mind. Any patient who on ultrasound, this also you should engrave in your mind. Any patient who has on ultrasound gallstones with a dilated CBD, we should always do MRCP as a next investigation. As a rule. Now, if you look at in your notes now, in theoretical discussion, you will find investigation of choice for CBD stones is MRCP. Right? So, when to do it? Now you know. When to do it? Now you know. Okay? Now, you have a patient who is found to have a CBD stone. Agreed? Your MRCP will tell you that there is a CBD stone. Agreed? Now, your diagnosis of CBD stone is established. आपने क्लिनिकल प्रेजेंटेशन समझ लिया, आपने अप्रोच समझ ली, अब आपको मैनेज करना है, राइट? इन मैनेजमेंट there are two ways of removing CBD stones: endoscopic extraction and surgical extraction. Endoscopic extraction and surgical extraction. Which one you will prefer? Why? Less invasive. Very good. So endoscopic extraction you will prefer. And what is that endoscopic extraction called? ERCP is an investigation. Endoscopic papillotomy or sphincterotomy. Okay. Endoscopic sphincterotomy or papillotomy. Now, if endoscopy, so preferred is endoscopic extraction. If it is not possible, sometime endoscopic extraction is not possible at your level, not required when it is not possible. If it is not possible, we are left with no choice but to do a surgical extraction. Right? And just note, this not possible usually happens when the stone is more than 1.5 centimeter in size. If the stone in CBD is more than 1.5 centimeter in size, usually endoscopic extraction is not possible. So when endoscopic extraction is not possible, we are left with no choice but to do surgical extraction. In surgical extraction, we have three options. In surgical extraction, we have three options. What are those three options? Supraduodenal choledochotomy, which is also called CBD exploration. Otomy. Choledochotomy means opening of the CBD, removing the stone and closing it with T-tube placement. Supraduodenal choledochotomy with T-tube placement is one of the option. Second option is transduodenal wasteful. Transduodenal sphincteroplasty. Transduodenal sphincteroplasty choledochoduodenostomy. Transduodenal sphincteroplasty choledochoduodenostomy. Just hold. Hello. अच्छा, बाकी रिपोर्ट भी रखो। हाँ ठीक है, थैंक यू। Out of these three options, preferred is supraduodenal choledochotomy with T-tube drainage. The preferred one is supraduodenal choledochotomy with T-tube drainage. And after this, just note this point, not a further detail required. After this surgery, we have placed a T-tube. We are supposed to put a tube in the CBD in the form of T, right? This is a CBD. This is a CBD. And we will put a tube in the CBD like this in the form of T, called T-tube, right? After this surgery, we are supposed to do a T-tube cholangiogram. You don't need to go into the detail of this. Just remember, we do a T-tube cholangiogram between 5th to 7th day. We inject a dye through this T-tube. If the dye is going freely into the duodenum, we will remove this T-tube. Removal of this T-tube is done between 7th to 9th day. Right? So, when to do T-tube cholangiogram and when to remove T-tube is important for us. So, these are the things we should know in a CBD stone. Then comes then comes acute cholangitis. Acute cholangitis. Now this acute cholangitis the most common cause of acute cholangitis is stones in CBD. Most common cause of acute cholangitis is stone in CBD. And how does a patient of acute cholangitis presents? A patient of acute cholangitis Charcot striae. A patient of acute cholangitis presents to us with a triad called Charcot striae. And in that Charcot striae, you will have pain, upper abdomen, jaundice, and fever also. A triad of pain, jaundice, and fever is called Charcot striae. These patients can have Raynaud's pentad also. These patients can have Raynaud's pentad also, which is Charcot striae with altered sensorium with hypotension. Now, can you tell me what is the first line of management in such patients? Nil per orally, IV fluids, IV antibiotic, and IV anti-inflammatory drugs. The first investigation will be investigation of choices, MRCP, right? And the treatment of this condition is treatment of this condition is biliary decompression. What do you mean by biliary decompression? Preferably endoscopically. Now what is happening in this? Please try to understand. ये हो रखा है. This has happened here. This is a scenario. In acute cholangitis, you know that this is a scenario. Agreed? There is a ampulla. There is a pancreatic duct and there's an ampulla here. So what we are supposed to do in these patients, there is a block here, which is the reason for these patients being in a acute problem. So what we are supposed to do, we don't need to do anything at this time, starting a NPO that we will do. And after that, what we will do, endoscopically, we will put a tube inside the biliary channel like this. So endoscopically, we do stenting like this. So when you put a tube across the obstruction, whatever the stagnant bile is there will come from this tube and will get drained. So the problem gets sorted. So once you have decompressed the CBD, later on, this is a CBD stone and then we'll manage it accordingly. So in acute cholangitis, the most important thing in treatment is biliary decompression, right? Which you do by endoscopic stenting. So this is how we manage a patient of acute cholangitis. Any doubt? हमने एंडोस्कोपिकली यहां से एक ट्यूब डाली, जो ट्यूब स्टोन्स के साइड से निकल के प्रॉक्सिमल चली गई, right? And the obstruction got relieved because of that tube. So the problem will get sorted. And later on, it is like a CBD stone. And how to manage that CBD stone? Now, endoscopically, endoscopic, surgical, surgical. गाइड वायर पे डालते हैं ना, गाइड वायर साइड से गाइड वायर जाती है, गाइड वायर पे, ठीक है. सो दिस इज हाउ, गॉट इट? Later on we do. Later on we do. Got it? Sure? Continue or break? Okay, let's take a break.